friends and brothers. Very welcome to the top 5 publications in IFSO APC in 2021 session. I'm Yorisuke Seki from Tokyo, Japan. And let me briefly introduce about IFSO APC Library Committee. And the committee was organized in 2019, just after Dr. Kazunori Kasama became the president, now taken over by Professor C.C. Wang of IFSO APC. There are 6 committee members: Dr. Wayang from China, Dr. Abish Katawa from India, Dr. Mark Magdi from Australia, Dr. Paulo Posincula from Philippines, Dr. Jiyon Park, Korea, and me. We collect all the PubMed index peer-reviewed papers about bariatric metabolic surgery, clinical, basic, and allied health from the AP region. Our donor, Ms. Manuela, post them to the IFSO APC website in a monthly basis. Actually, the activity in AP is very active, and we are listing 40 to 50 publications per month in average to the website. Today, we nominated 5 excellent published papers published the first half of this year and asked each authors to directly present their study. After, so it's Dr. Ahmed Ali from Australia and Dr. Wayang co-chaired the session. And again, we are asking 2 distinguished experts, Dr. Lilian Ko and Dr. C.C. Wang, for panelists. So let's enjoy the program. Ahmed, can you please introduce the first speaker, please?
Certainly, thank you, Yoseki, and welcome everybody. Again, as everyone has said, it would be nice to be doing this all together in the same room, but unfortunately not this year, maybe next year. But at least we can get together and hear these excellent papers. So I'd like to introduce first the first paper. It comes from India. Dr. Uttam Thakur in Chandigarh, India, is to present his paper today on liraglutide augments weight loss after laparoscopic sleeve gastrectomy, a randomized trial. Dr. Uttam.
Namaste, myself Dr. Uttam Kumar Thakur from India. I would like to sincerely thank IFSO for giving me this opportunity to present my research work in front of other researchers. My study is liraglutide augments weight loss after laparoscopic sleeve gastrectomy, a randomized double-blind placebo-controlled study. Laparoscopic sleeve gastrectomy is getting increasingly popular due to its technical austerity and fewer complications compared to other bariatric surgeries. Liraglutide is a long-acting GLP-1 analog approved for weight management in adults. Both of them are proven to cause a significant weight loss. The objective of our study is to find the effect of addition of liraglutide after LSG in first 6 months post-surgery on excess body weight loss and obesity-related comorbidities. It was a prospective double-blind randomized control trial. Obese patients with BMI 30 or more and age between 18 to 65 years were included in the study. There were certain exclusion criteria like prior use of GLP-1 agonist therapy, previous bariatric surgery, gastric surgery, or complex abdominal surgeries. Participants undergoing LSG and fulfilling study criteria after formal consent were randomized into 2 groups to receive either liraglutide or placebo from 6 weeks post-operative until 6 months. The first group received liraglutide 0.6 mg per day. The dose was increased 0.6 mg every week till maximum tolerated dose or until 3 mg was reached. The other group received placebo similarly. Weight-related outcomes were measured. Glycemic parameters and resolution of type 2 diabetes mellitus was measured. Dyslipidemia, blood pressure, Framingham score, sleep apnea score, a GRD score, and quality of life outcomes were measured. Primary endpoint was % extra body weight loss at post-operative 6 months. During the study period, total 32 patients underwent LSG at our center, of which 9 were excluded from our study. 27 patients met inclusion criteria, out of which 4 patients did not provide consent. So total 23 patients were randomized and were included in our study, of which 12 went into liraglutide arm and 11 went into placebo arm. Of placebo arm, 1 patient died at 10-week follow-up because of MI, but it was included in the analysis modified intention to treat. The baseline characteristics of participants were similar in both the groups. The impact of our intervention on weight parameters depicted in this chart. We can see here that extra body weight loss percent at the end of our study, that is 6 months. In liraglutide group, it was 58.7 plus minus 14.3%. In placebo group, it was 44.5 plus minus 8.6%. And this percent extra body weight loss difference in both the group was statistically significant. This graph depicts that the patients in liraglutide arm had additional extra body weight loss, which was 14.2% over and above that of placebo arm of the patients. All patients with diabetes or pre-diabetes had resolution of glycemia in liraglutide group as compared with 50% in placebo group. There was improvement in obesity-related comorbidities in both the groups with no significant intergroup difference at 24 weeks. Coming to adverse events, no mortality or major complications in the immediate post-operative period was noted. 10 patients complained of transient hair loss, which resolved by 6 months. Nausea, vomiting, headache were most common complaint and were similar in both the groups. Coming to the strength of our study, the novel concept of adding medical intervention to LSG in early post-operative period was most important. Placebo drug control design, there was a good adherence to study medication by the patient. Rigorous follow-up lended robustness to our data. Small sample size and short follow-up period was the major limiting factor of our study. From our study, we concluded that liraglutide, when added early after LSG, significantly augments weight loss in obese individuals during the initial 6 months. A longer duration follow-up study is desirable to confirm or deny additional benefits for other obesity-related comorbidities.
Okay. Very good presentation, I think. May I have a question? Dr. Utham, can I have a question for you? I think this is very important research. I want to know, are there any patient having no effects by using this drug after surgery? And what is the percentage?
Tom, did you follow that question? I think you're muted, Tom, we can't hear you.
So please repeat if possible, sir. Actually, I was...
CC, can you just repeat the question?
Okay, I want to know, are there any patient have no effect by using liraglutide after surgery, and what is the percentage?
Sorry, Tom, just repeat that again. I think your microphone didn't work.
All the patient had effect of liraglutide.
So all the patients seem to have a response to the medication, yeah? That was the feeling you got. Why would you have a question for this paper? Dr. Wai Yang?
Yeah, and may I ask, after this study, will you recommend, in your opinion, will you recommend the patient with a low BMI, for example, just over 27.5 to 32, the Asian population, will you recommend them for medical treatment or surgical treatment if the patient had type 2 diabetes?
So in our study and what we are usually following it here, we are not advising surgery to patients with BMI less than 30 at present. But endocrinology department people are giving this medical treatment for obesity for BMI less than 30.
Hello.
Okay.
Hey, I
Yes,
have a
okay.
question. Yes.
Okay,
I
last
have a
question.
Yeah, I have a question. And then, so it's you you administer the GLP-1 for the first 6 months, right? So it's
Yeah.
So it's what happened after 6 months?
The patients are in follow-up, but after 6 months, our study ended. So those patients who were willing to take liraglutide, those patients felt that after stopping liraglutide, they're not losing weight. We asked them to continue the medications, but that part is not included our study, so we don't have exact data about that patients. That whether they continued liraglutide or not, we don't have exact numbers, but many patients we allowed them to continue.
So Uttam, I think we would all be very interested to see you in the meeting again next year telling us what happened to these patients 12 months later. Of course, understanding it's a small sample, but it would be interesting to know what happens in the longer term. We'll move now to the next paper. I'd like to introduce Dr. Chang Ho An, from the Department of Internal Medicine at Seoul National University in Korea. And he's speaking about the vertical sleeve gastrectomy inducing distinctive transcriptic responses in the liver, fat, and muscle in a rat model. So everybody, you need to put your science hats on now and listen very carefully.
I am Chang-Ho An from Seoul National University. I sincerely thank to the committee for giving me this opportunity to share the results of our study to other researchers. Our study is about the effect of sleeve gastrectomy to peripheral tissues, especially gene expression changes in liver, fat, and muscle. We aim to investigate how VSG affects gene expression in peripheral tissues that participate in glucose metabolism, and weight loss dependent and independent effects of VSG on peripheral tissues. We also wanted to compare the difference between VSG and round-eye gastric bypass in terms of peripheral tissue gene expression. To do this, we performed RNA sequencing of liver, fat, and muscle. We had two control groups, sham and sham-parafat, which was matched food intake to VSG mice. We made our own VSG mouse model, but to compare with RIGB, we used open dataset of RIGB mice from GEO database. VSG reduced body weight only after surgery, and this difference was maintained until 8 weeks. Sham parafat had initially similar body weight to sham, then followed VSG group. The food intake was reduced after VSG only during post-operative period. The oral glucose tolerance test showed well-known pattern of early rise and fall of glucose in VSG mice. Insulin tolerance test showed improved insulin sensitivity in VSG mice, but this was similar to sham parafat. Postprandial insulin and GLP-1 secretion was clearly increased in VSG compared to sham or sham parafat. Collectively, these mouse phenotyping results showed that our mouse VSG model was well established and reproduced some characteristics of VSG. In histology examination, fatty liver was improved and adipose tissue inflammation was improved in VSG, but this was comparable to sham parafat. However, when we see gene expression, VSG showed clear weight loss independent effects, which can be depicted from the comparison between VSG and sham parafat. And this effect was even more robust than weight loss dependent changes, which can be seen from comparison between sham parafat and sham. Interestingly, liver showed the most prominent gene expression changes, and muscle showed least changes. When we see the gene ontologies of differentially expressed genes in liver, compared to sham or sham-perfect, several metabolism-related pathways were downregulated, and immune response-related genes were upregulated. Gene ontologies of differentially expressed genes in fat also showed similar results, that immune response-related genes were upregulated in VSG mice compared to sham or sham-perfect mice. Lastly, we compared VSG and RYGB effects on peripheral tissue gene expression. Left panel shows the correlation coefficient of gene expression changes between RYGB and VSG among whole transcriptome or each metabolic or immune pathways. The correlation coefficient clearly shows that the gene expression pattern of liver showed highest concordance between VSG and RYGB. In the right panel, the gene expression patterns of liver, fat, and muscle of VSG was similar to RYGB, but RYGB had more augmented changes. In summary, VSG improved glucose tolerance and induced sustained body weight loss to a similar extent as parafat sham controls. VSG induced global gene expression changes in the liver, fat, and muscle. Among the three organs, the liver showed the most prominent gene expression changes after VSG. Immune response-related pathways were commonly upregulated in the liver, fat, and muscle. VSG-induced gene expression changes in the liver, fat, and muscle may play a critical role in the metabolic improvements after VSG.
Sorry, I was
Aman?
muted.
Yeah.
I'm sorry.
Yeah.
Yes, Suzuki, you've got a question. We're opening this paper now to questions. You've got a question here for Chang Hao An.
Should I answer to the question?
Yes.
Okay. So the question is, did you find any difference between sleeve and bypass? I mean, what would be the impact of adding intestinal bypass? Maybe effects can be similar, but sleeve gastrectomy and bypass is definitely a different operation. In our study, we only saw the gene expression changes in peripheral tissues, and as I mentioned in last part of the slide, the pattern was similar between sleeve gastrectomy mouse and Raman gastric bypass mouse, but it was more augmented in gastric bypass mouse. So I think the effects of bariatric surgery, sleeve gastrectomy, and gastric bypass are similar to these peripheral tissues, but maybe gastric bypass had more prominent effects on peripheral tissues. And we don't know the exact mechanism underlying this phenomenon. Yeah.
Chang Hao An, this is quite an interesting paper, and you're showing some differences there in gene expression and regulation. You also showed some differences in hormones. So, for example, the insulin response was greater in the sleeve rats compared to the sham pair-fed. Okay, so we're seeing genetic difference, we're seeing hormonal difference, but we didn't see end organ difference. So the glucose response was similar, for example. The fatty liver change was similar, for example. So can you speculate, what do these changes mean in the long term? Is this just an observation, or are they meaningful, these weight-independent effects?
Yeah, thank you for the question. And yeah, I think your question is very important. And this is just my speculation, but you know, we don't know yet clearly, but there are some arguments that bariatric surgery may have more effect and maybe some pleiotropic effect more than just same amount of weight loss by calorie restriction. So maybe these peripheral tissue gene expression changes I saw in our mouse model may be related to this pleiotropic effect of bariatric surgery. But yeah, I don't know how to correlate this result to clinical findings or human relevance.
Yeah, I look forward to your further work. I think it would be very interesting. One of our fellow speakers has asked a question about could these gene transcription changes be influenced as a secondary effect? So, for example, if there was a change in the microbiome, could that create these genetic changes, or do you think it's a direct effect of surgery?
We didn't test that hypothesis, so we don't know. But my opinion is that maybe is more directly related to surgery, and you know, microbiota can be changed after antibiotics, or just weight loss can induce profound microbiota changes. And we used pre and post-operative antibiotics. We gave antibiotics to our mice, so these antibiotics may affect microbiota too. And yeah, I think maybe this the operation is directly affects the peripheral tissue expression. Yeah.
Thank you. Yeah, it's very interesting. As I said, we look forward to your future work. It's a really interesting area. We'll move now to the next speaker. The next speaker is Professor Jeffrey Hamdorf from the University of Western Australia in Perth, Australia, so in our homeland. Welcome, Jeff. Jeff's speaking to us about patterns of change in device-based physical activity and sedentary time following bariatric surgery. This is a longitudinal observational study. If we could have Jeff's talk, please. Thanks.
Good afternoon, and I'd like to thank you for the invitation to present at this meeting. My name is Jeff Hamdorf. I'm coming to you from Perth in Western Australia. I'd like to talk to you about patterns of change in activity in our patients following bariatric surgery. This data is presented having been collected several years ago. I am the current president of ANSMOS. As you're aware, I work in private practice and am a surgical academic at the University of Western Australia. I'd like to talk to you about this project, this paper that was published earlier this year in obesity surgery, and at the outset acknowledge Dr. Juliana Zabatiro, whose PhD this arose from as a joint project across the University of Western Australia and Curtin University, with the patients being collected from our private practice. Patients were able to be included if they were adults, had a BMI of above 30, and had one of our restrictive procedures. The typical exclusion criteria are applied, and assessments were done both preoperatively and at every 3 months post-op for 12 months. These were the devices that were used to measure the primary outcomes, that's physical activity, and these are validated accelerometer style devices, which are very reliable and discreet as well. We also looked at a variety of other outcomes, typical weight-related outcomes, but also fitness outcomes and this concept of self-efficacy to exercise, the preparedness to go ahead and exercise. And oftentimes our patients will tell us that the only thing holding them up from exercise is their weight or the impact of their weight-related complications. We wanted to test this in a valid, robust fashion. we included the data if it was a minimum of 4 days of data at each time point, at least the majority, at least 12 hours per day of wearing time, and over weekends as well. And then we split the intensity of activity into sedentary, which is the equivalent of sitting in a chair, all the way up to moderate to vigorous activity, and that might include walking at a brisk rate, maybe above 6 or 7 kilometers per hour, social, badminton, and the like. And then the data were analysed according to physical activity, sedentary time, and self-efficacy was compared as well. And I have to say there was a surprisingly low participation rate. We had around 180 patients were eligible, but only 36 agreed and only 30 actually ended up completing, which I found surprisingly low. But it was quite a deal of engagement necessary by the patients. The patients lost weight. They had positive effects on body composition at every point, and most pronounced at 3 months. There was an increase in self-efficacy to exercise, meaning patients were more positive about the ability to exercise. However, surprisingly, there were no changes in the amount of sedentary time undertaken versus light physical activity undertaken versus moderate or vigorous physical activity. So there was really no change in their activity levels. And this occurred at all points during their waking hours, with almost no time engaged in moderate to vigorous intensity physical activity. The step count remained the same. Cardiovascular fitness did not improve over the 12 months of study. This shows that standardized measures and valid measures of fitness did not show an improvement after bariatric surgery. This was in spite of significant weight loss and improvements in self-efficacy for exercise. So we know bariatric surgery works, but it wasn't enough to affect a change in physical activity. And I think it suggests that if we're looking to improve patients' physical activity, then we need to think about other behavioural interventions to help optimize this change. Thank you very much.
Thanks, Jeff, and I think that's probably a surprising finding for many of us. I want to throw to Lillian. Lillian, our president, do you have a question for Jeff on this paper? I'm sure there's lots of questions that can come to mind here.
I enjoyed your talk, Jeff, and I'm surprised that there was no difference in their activity. So in your opinion, what kind of behavioral changes should we be introducing to these patients to encourage them to get out of their old habits?
That's a good question, and thank you, Lillian, and thank you for the rest of the panel for this opportunity. I think when you look at patterns of exercise and you ask people about their exercise, people will exercise if they've got someone to exercise with. Generally, we talk about an exercise buddy, and I think that's really important. We are all, I think, prepared to let ourselves down, but far less prepared to let a buddy down. So you can provide all of the background, and we send our patients off to see an exercise physiologist, and that's provided as part of the program. And they get taught how to exercise. They are encouraged to exercise in the way that suits them best. But still, when we measure it, and these were the enthusiastic patients. I'll remind you that that of the 280 we approached who were screened, 144 said they just weren't interested, or they weren't going ahead with surgery for whatever reason. They just weren't engaged enough to be measured in terms of their activity. We took the 30 motivated ones who said, yes, I'm going to work harder, I'm going to exercise, and we proved that they didn't. So I think you can take a horse to water, but you can't make it drink. I think it will come to behavioural activity, so encouragement and actually getting them out there and doing it properly.
So Yusuke, you had a sort of similar question. Was there anything you wanted to ask in addition? No, that's okay. So Jeff, I wanted to ask, are we just missing the barriers? Like maybe there's other barriers that are stopping them. They think it's their weight, but maybe it's their they're busy with their kids and the jobs and things, and they just sort of can't get there.
Oh, well, look, the other thing to be aware of is that we run a practice in the middle of a big city. And the patients come from the outer suburbs, and I think, you know, Western Australia is huge. It's about 3,000 kilometres from north to south, and we have patients coming from all over the state. And so they have different lives away from the city, away from talking to us. We only see patients for a very small snapshot of their lives, and they will say the right thing, I think, to get the operation that they know they need. And we know they need it. We know they're going to benefit metabolically from the surgery, but we're so much happier if they can demonstrate cardiovascular fitness improvement as well. And
Of
so
course.
they'll say,
And finally, I have to ask this question because I think we all see it. We see the outliers. We see the ones that were sitting on the couch that go to running marathons and, you know, doing stair climbs and everything else, and we see them. Did you see the outliers in this study? Did they appear? Did you see differences in pre and post activity in individuals, even if overall it didn't seem to be different?
The differences were minuscule and they were not significant. And I know the outliers as well. I'm very proud of my outliers, and they're very, very proud of themselves, but they didn't appear in this study, I'm afraid.
You need to recruit differently. All right, we'll move on. Thank you very much, Jeff. Excellent stuff. So the next paper comes to us from Yuming Wang. He's speaking about the long-term outcomes of metabolic surgery in overweight and obese patients with type 2 diabetes in Asia. He's from the Taipei Medical University. Let's have a listen to that talk.
Dear colleagues, I'm Dr. Huang from Taiwan, presenting the topic of long-term outcomes of plastic surgery in overweight and obese patients with type 2 diabetes in Asia. Up to 90% of patients of T2D do not achieve treatment goal with medical treatment alone. This is where the metabolic surgery comes into play. Short-term remission rate of more than 80% may be achieved according to previous studies. Therefore, the International Diabetes Federation recommended that metabolic surgery be considered a treatment option for selected patients fulfilling these criteria. More than 60% of the world's T2D patients come from Asia, and the incidence is increasing rapidly. The burden is disproportionately high because of onset at a relatively young age and low BMI. Unfortunately, most current evidence regarding the treatment effect of metabolic surgery came from the West or studies of small patient number. Therefore, we review the data from the ADSS to assess the outcomes of metabolic surgery in Asian patients with T2D. The database comprised 12 centers from 6 regions. There were 1,999 patients who were older than 18 years and with BMI greater than 25. The diagnostic criteria for T2D were according to the American Diabetes Association. The procedures performed included A. Single anastomosis gastric bypass or SAGB, B. Roux-en-Y gastric bypass or RYGB, C. Sleeve gastrectomy or SG, D. Duodenojejunal bypass with sleeve gastrectomy or DJBSG, and E. Laparoscopic adjustable gastric banding or LAGB. The outcome measures, including T2D remission, recurrence, and composite triple endpoint, were also defined according to the American Diabetes Association guidelines. Most patients were from Taiwan. SAGB was the most commonly performed procedures, followed by RYGB and SG. Weight, BMI, sugar, HbA1c all decreased significantly at 1 and 5 years. Parameters of insulin resistance also improved. The rate of diabetes control and remission remained relatively constant over 5 years. Other metabolic derangement, including blood pressure and lipid profile, also improved significantly. About 25% and 30% of the patients achieved composite triple endpoint at 1 and 5 years, respectively. When we look into the change in effect over time, we can see that body weight and BMI were lowest at 1 year, with gradual increase afterward. On the other hand, variables of diabetes control remain low. Lipid and blood pressure levels also remain low after 1 year. When we look at the effect of different procedures, we can see that SAGB and other bypass procedures perform better than SG in weight and BMI. The effect was the least for LAGB, whereas the effect on sugar and HbA1c was the most prominent for SAGB and the least for LAGB. SAGB also has the most common effect on coma, while SG has the most common effect on number of medication. The effect on blood pressure was the most prominent after SAGB and DCB-SG, and was the least after LAGB. The effect on lipid profile was similar for all procedures, except that LAGB was the least effective for LDL cholesterol. We can conclude from this study that metabolic surgery yielded remarkable and durable improvement in body weight, T2D, other metabolic disorders in Asian patients. LAGB was the least effective, whereas SAGB was the most effective treatment for metabolic disorders. This variation in efficacy among different procedures should be considered during treatment planning. Thanks for your attention.
Thank you, Yumin Hung. Thank you. We'll open this paper now to questions. Professor CC, how about your experiences? Do you have a question here for this paper?
Okay. Dr. Yumin Huang, your presentation I think is very interesting. We usually in Asia we have difference compared with Europe and American. But in Asia, we know East Asia, South Asia, West Asia, maybe have difference. What do you think about this question?
Yeah, I think the difference may come from many aspects. First of all, ethnicity may have some effect. And second, the procedure performed may have a major role. According to our study, most of patients are from Taiwan, and the most performed procedure was the SAGB, account for about 1/3 of the patients. That's quite different from today's situation and in the West.
Okay, thank you.
Wah Young, we haven't heard from you for a little while. I'm sure you've got a question here about diabetes in this population. I think you might be muted.
Okay. Yes, thank you, Dr. Wang, for your presentation. And may I ask, do you have any tips for other researchers to maintain the long-term follow-up rate in such a large cohort study? Because in many papers, they just have a very short-term follow-up, or the follow-up rate is very low, so that may weaken the evidence or the quality of the paper. So do you have any tips? Are the patients voluntarily coming back for follow-up, or you just push them to come back to hospital?
Okay, thank you for your question. I think it's a very important issue because even in this database, the follow-up proportion among different institutions and different variables. So this is really a problem. I think we can only improve this with the well-trained personnel that can, and the dedicated person to take the responsibility of follow-up. Thank you.
Are the patient your own center, or they just go into the hospital nearby at their home?
During that time, there are not quite. There are only a few centers capable of performing bariatric surgery, so it's quite something like a centralization. Not like nowadays they can shop around different hospitals. So it would be more difficult to keep track of this patient nowadays.
I see. Yeah, that's an important point. Yosuke Seki, Doctor, you've also asked a question here on the messaging, but I'll let you, you raise the question.
Yeah. So first of all, congratulations. But my question comment is an IDF or DSS2 guideline recommend bariatric metabolic surgery for class 1 obese Asian patients who are poorly controlled diabetes. So I assume not everybody included in this analysis may not be poorly, medically uncontrolled diabetes. Do you have any comment for this?
Sure. We also noted that, and some patients are do not fulfill the criteria about BMI. So after discussion, we include patients in the category of overweight to make the great use of the best use of the database.
Dr. Huang, there's a question from one of your fellow speakers, is wondering, why do you think the single anastomosis was the most effective in your population?
Okay, I think honestly, because the data in Taiwan was mostly contributed by Dr. Wei-Jie Li, who is a great proponent of the SAGB. And so I think there's actually this may be some kind of bias, but it reflects the situation at that time.
I see. Can I ask you, for your Roux-Y bypass, what length was the biliopancreatic limb?
Oh, okay. It's about 100 to 150 centimeters.
Is that for the single anastomosis or the Roux-Y?
It's for the single anastomosis, it's around 200.
Okay. Okay, thank you. We need to move on. There's too many questions for all the papers. It's very good. There's a lot of interest. So we're going to move now to the last paper, again from Korea. Dr. Kwon is speaking to us about metabolomic analysis of the improvements in insulin secretion and resistance after sleeve gastrectomy and potential implications for novel biomarkers. If we could have that talk, and then we'll end again with questions after.
Hi, my name is Young-Keun Kwon from Korea University Hospital. It is a great honor to present in IPSO-APC Congress. And the title of my article is Metabolomic Analysis of the Improvements in Insulin Secretion and Resistance After Sleeve Gastrectomy, Implications of the Novel Biomarkers. I have no potential conflict of interest. Metabolomics is a relatively young field among the different types of omics. We use this methodology to study low molecular weight molecules comprehensively. And through this, we can understand the molecular dynamics affected by intra and extracellular regulation and enzyme functions. Especially in the field of bariatric surgery, metabolomics is usually used to investigate the mechanisms of the metabolic effects following bariatric surgery. And metabolomics help us to discover biomarkers for preoperative prediction of metabolic outcomes. Interestingly, various metabolites in our body shows drastic changes after bariatric surgery. Some of these goes up or down after surgery, and researchers are trying to understand the clinical implications of those changes. Among various metabolites, we are focusing on amino acids related metabolites. Previous studies show that branched chain amino acids, aromatic amino acids, and various tryptophan-derived metabolites are related to diabetes or insulin secretion or resistance in human body. So we investigated whether these amino acid metabolites are related to insulin secretion or resistance after bariatric surgery. This study was a prospective single-arm longitudinal study, and we enrolled 23 patients with type 2 diabetes. All patients experienced the sleeve gastrectomy, and we quantified 16 metabolites in patients' serum pre and 3 months post-surgery. Patients' BMI at baseline was 38.9 and average duration of diabetes was 5.5 years. 2 patients used insulin for glycemic control. At 3 months after sleeve gastrectomy, patients lost 19% of their initial weight and glycated hemoglobin decreased from 7.5% to 5.9%. In this study, we used 3 indices to measure insulin secretion or resistance. Insulinogenic index was used to estimate the insulin secretion, and HOMA-IR and Quickie indices were used to estimate the insulin resistance. Insulinogenic index increased at 3 months, which means the improved beta cell function. HOMA-IR decreased and Quickie index increased at 3 months, which means the improved insulin secretion, insulin resistance. This table shows the changes of metabolites. BCAA, aromatic amino acids, and quinoline pathway metabolites derived from tryptophan decreased at 3 months after surgery. When we tested whether preoperative levels of metabolites were related to the improvements of insulin secretion and resistance after surgery, leucine, tryptophan, phenylalanine, tyrosine, and some of quinoline pathway metabolites showed statistical significance. Among those metabolites, LNAA, which are some of BCAA and aromatic amino acids, and phenylalanine showed superior prognostic performance for the improvements of insulin secretion and resistance 3 months after sleeve gastrectomy. Indole compounds, which are tryptophan-derived gut microbiome metabolites, showed a different relationship with insulin secretion or resistance in bariatric surgery patients. While baseline level of indole compounds did not show the significant relationship, the changes of them were related to the study outcomes. Increase of IAA was related to the improvement of insulin resistance, and decrease of IPA was related to the improvement of insulin secretion after surgery. This is conclusion. Through this study, we noticed the possibility of amino acid metabolites as potential biomarkers for insulin secretion or resistance after sleeve gastrectomy. We need to further elucidate the biological mechanisms, how these metabolites contribute to beneficial effects following sleeve gastrectomy. And the performance of these metabolites as biomarkers need to be validated in future studies. Thank you for your attention.
Thank you, Dr. Kwon. So that rounds out all of our speakers. We'll take questions on this paper. Lillian, can we come to you first?
Yes, of course. Dr. Kwon, I enjoyed your paper. I was curious that how amino acids being little tiny protein molecules, can you postulate how these little tiny molecules as protein can influence the metabolism and become prognostic indicators, from results of metabolic surgery?
Thank you for the good question, Lillian. As I said, the majority of circulating amino acids may directly promote insulin resistance, possibly by disrupting insulin signaling in the skeletal muscles. And we can see the increased serum levels of amino acid metabolites in insulin-resistant humans. In bariatric surgery patients, I think hyperaminoacidemia may identify subgroups in whom type 2 diabetes is mainly induced by insulin resistance and beta cell function is relatively well preserved. About these points, we need further research.
I see. So, Dr. Kwon, I had a similar question, but I think you may have gone part way already to answer that now. This paper shows a very interesting correlation in the change of certain amino acids after surgery. But as I understand it, the baseline levels were not predictive of how good the response to surgery would be. But can you reverse engineer this? Are we missing something? Could there be an amino acid marker that could tell us or predict the response of diabetes to surgery?
Oh, thank you for the question. Regarding the Indo compounds I investigated, interestingly, our results show while the IPA, which is the abbreviation of one of the Indo compounds, and IPAA level at baseline and 3 months did not differ significantly. But decrease in the IPA level and IAA level was associated with better improvement in insulin resistance or secretion. Although we need to validate the data of gut microbiota, we can get a hint that modulation of gut microbiota composition might be important to improve glycemic control after surgery. And in future study, I have a plan to incorporate amino acids in the existing several scoring masses for predicting diabetes prognosis. And if these incorporated scoring masses, if we have incorporated scoring masses, we could have more improved prediction masses.
Yeah,
Thank you.
I think this is where this work could lead, is having biomarkers that predict response and maybe tailor surgery. So that would be very interesting. We probably have time for just one more question from the panel, if anyone has a burning question for this paper. No? I think Yusuke must have some question. He's always thinking like this. Oh, you're muted. I think maybe Manuela is muting you, telling us we're out of time. So we better hand over to Wah Young. Dr. Wah, could you close the session for us?
Okay. Thanks everybody, especially our 5 speakers and also our 2 panelists, Professor Lilian Ko and Professor Cici Wang, and also our moderator Yusuke and Elmet for joining us. And actually, there are many other outstanding papers in the IFSO APC library, but we can only select 5 papers due to the limitation of time. So for the rest, we can find it on the IFSO APC website. And actually, the IFSO APC library was initiated by our president, Professor Kasama. And the new president, Professor Cici Wang, just told me that we should keep doing this. And so let's look forward to seeing more collaborative research and papers published from Asia. So If there is no other business, may I close this session? And thank you very much for joining us today. Thank you.